Visible?
Yes, sir. Yes, sir.
So question is, what do you mean by multi-casualty triaging? How do you triage victims in the casualty of following mass disaster? Okay, so that is how the question is worded. So the word triage means to sort. So multi-casualties means resources can be given for individual patients, and the triage system has 5 levels. Level 1 is immediate and life-threatening. Level 2 emergency could become life-threatening at any moment. Third is urgent but not life-threatening. Fourth is semi-urgent, not at all life-threatening. 5 is non-urgent, needs treatment when time permits. Otherwise, for example, a minor scratch or both bone fracture forearm patient, group of patients who have multiple fractures, abdominal injuries, head injuries. So this person with a fractured both bones, forearm, and a small laceration in the shoulder is not the urgent person. So depending upon the nature of the injury, you classify them into that. So mass casualty incidents can be referred to as conventional or catastrophic. In conventional mass casualty, incidents occur with somewhat regular frequency, such as large vehicular crashes or severe weather events. Whereas catastrophic mass casualty occurs less commonly. So this, if it is occurs rarely, it is called catastrophic. Things that happen regularly. For example, you read about road traffic accidents every day, and you read about weather change events like floods and other things, people dying. They are all conventional, which happens regular frequency. Whereas volcano eruption or a bomb blast somewhere, these are all rare things that happen less frequently. So there are color coding given for identifying the patients, where if you have a red tag, it means the patient is immediately requires attention and is critical. They may have airway and breathing difficulties. They may have severe bleeding. Their altered sensorium will be there, hypoperfusion, or they may be suffering from severe burns, or open and chest or abdominal injuries, have maybe a severe medical problems. All these things, patients are classified as critical. Second is delayed or urgent, who are given yellow tag or yellow coloration. So in that group, you carry these tags and immediately tie it to the patient, so that people trying to transport them will know how urgent the patient is. So burns without airway problems, major multiple bone joint injuries, back injuries without spinal cord damage, they come under second category. Third is minimal or minor. They have a green tag. Minor painful, swollen, deformed extremities, minor soft tissue injuries. And the fourth is expectant or disease, black tag patients. They are almost dead. Obvious signs of death is there, or there is a non-survivable injury like decapitation or a major brain trauma, respiratory arrest, cardiac arrest, all these things, they are classified. So this is a basic color coding for identifying the severity of the injury. So the initial primary triage assessment will have to be done within 30 seconds per patient. So when you have a large number of patients, you can't be going on examining each and every individual like you do in your ER. When patient comes, of course, you have a medical legal responsibility. You have to note down each and every injury that has happened. But here in a massive casualty, the primary triage, you should not spend more than 30 seconds per patient to identify whether he belongs to the black, red, or green or yellow category. And the purpose of this is to rapidly identify those patients who really need life-saving intervention. And it is usually executed as an algorithm which is called modified triage series, MPTT24. And this is designed to rapid, reliable, reproducible, irrespective of provider performing. Whoever performs should be able to do that. So this should be like a protocol which we follow, followed by a secondary triage process, which typically takes place in a more pervasive environment and is performed by more experienced clinicians. So the primary triage, all paramedicals also should be able to do that. Whereas when it comes to secondary triage, it becomes a more experienced person. So a number of different secondary triage processes exist, which are called triage, short anatomical triage. You just mention the name, it is more than enough. And these are all the things that are used to calculate the conscious level, like the GCS score, and then the triad chart score, and the assessing the priority. Once you do that, this is the step. So step 1 is to assess the GCS. Step 2 is to go for the triad chart score, like respiratory, systolic blood pressure, GCS, all the three, because these are the three primary systems which are involved. You go to that, then go to the assessing the priority, like the whether the patient belongs to green or yellow or red or black. Here it is given in blue, but it should be black color. And during triage in mass casualty, patients are grouped into the following categories, like red, yellow, green, blue, or black and white. And once the catastrophic hemorrhage happens, then it becomes the red category. Apply tourniquet or hemostatic devices. If the patient is walking, then we go to green category. So we don't give too much of attention to them. Then if he is breathing or not identified, then no pulse, no respiration, goes to the dead black category. Then response to voice, put in recovery position, go to again red category. Respiratory rate based on that 12 to 23, no, that means you go to red category. Yes means heart rate less than 3. So like that you sort out the patient's priority based on their physical findings, and then all these things should not take too much time, because we are seeing only the three systems: CNS, RS, and respiratory rate. So based on that, as I said, 30 seconds should be enough to assess the patient and categorize them, and then utilize the responsibilities that are there. Then this is the start simple triage rapid system. Again, for another, the flow chart is given. So how to do that and categorize them again. All these things finally lead to whether it is a dying patient, ignore them, go to treat the other patients and try to save them. So just mention the name, start regime, and start algorithm. So these are the two algorithms which you can just make sure to write it. Step 1 is not for able to walk, able to wave or make other purposes of movement, lying still or obviously severely injured. This is the first step to assess how their conscious level is. Second, individual assessment, life-saving intervention, controlled major hemorrhage, open airway, chest decompression, auto-injector, antidotes, etc. And then if the patient is breathing or not breathing, then declare him dead. Then go to the other things, to see whether he is minimally affected or he can be delayed for some time, or whether he has to be immediately taken care of and then started treated. So ultimately, majority of the seriously injured patients may either be already dead or within the range of dying. So these two categories, you should not waste your time, and spend more time on the patients who can be saved by assessing these three systems and then try to triage. And that is how we try to manage that. Okay, so that is in a very short form of how to do the triaging and how it is useful to write the answers. Based on that, you can expand that. Okay.